in this series also, Dr. Sunita asked me what is the meaning of blossom. I've been explaining about the meaning of blossom in all the webinars. We have selected this name, unique name, because the blossom means the flowering part of a plant which will become a fruit. So this is a reproductive medicine webinar, and it is our pleasure to have Sonia Malik ma'am, who is such a dynamic person, past infertility committee chairperson of FOGSI, and also she was the president of IFS. Uh, occupied various prestigious position national level and also in the international level. It is our honor to have you here, ma'am. And we have our own Sampath Kumari ma'am as a guest of honor, who is past vice president of FOGSI and also secretary general of Tamil Nadu Federation of Obstetrics and Gynecology, and she has got a recent goal to achieve in another 2 months, and wishing her best wishes in the near future, and occupy the prestigious position in the India and also in the international level. And we have very interesting topics today. Troubleshooting in IUI, that will be moderated by none other than Dr. Sunita Arora. IUI, even though it looks simple, we encounter various difficulties starting from sperm collection to negotiation of cervix. So we have wonderful panelists, Dr. Anuradha Tyagi, Dr. Surita Karim, Dr. Madhu Gulati, Dr. Sudhir Gupta, Dr. Shikha Tandon, Dr. Arun Singh, Dr. Sharda, Dr. Shabina Khan. We have wonderful panelists, and I know we are going to have a great discussion in this. And the other topic is embryo insight. Anyway, embryo is not discussion. We have Dr. Charlata Chatterjee, who is going to moderate that panel, and we also have experts, Dr. Nishant Singh, Dr. Suhashini, Dr. Fairy, Dr. Mohammad Akdas, Dr. Nidhi Singh, Dr. Sindhuja, Dr. Gaurav. It is a great honor to have you here in this wonderful discussion, and I also thank Dr. Safrin, who is going to coordinate this. With this discussion, I'm very sure that our delegates will be really benefited out of that. I also thank Dr. Shanta Devi ma'am, who is Secretary of YAMCA, who had also joined in this webinar, to welcome you. Thank you so much.
Thank you, ma'am. Now lighting the Kuttu Velakam, ma'am.
So, it is my honor to introduce Sonia Malik ma'am, who doesn't need actually any introduction. Actually, she was the past president of, past chair of FOGSI Infertility Committee, and chair of Advocacy Committee, IFS 2018, past president of IFS 14 to 16, past president of Indian Menopausal Society 2007 to 2008, AOGD Infertility Committee Chair 2011 to 13, Vice President IMA South Delhi 10 to 2011,
Let's finish.
Indian representative of at least first half I will just read, man. Indian representative to International Menopause Society 2009 to 11, Indian representative to Asia Pacific Society of Menopause 2011 to 13, Indian representative to the World School of Menopause 2009 to 2013, Associate Editor, Southeast Asia Journal of Global Health, IFFS, Member Editorial Board of Fertility and Sterility of India, Member Editorial Board, Journal of Reproductive Health and Medicine, past Editor-in-Chief, Journal of Midlife Health, Member ICMR, Task Force on Genital Tuberculosis and PCOS. We know you as a fertility expert, but you are into Menopausal Society and also each and every corner of India. Welcome, ma'am. Please give us your blessings and words of wisdom.
Thank you so much. First of all, thank you so much, Dr. Kalpana, Dr. Shanta, and Dr. Sampath, and all of you here from this wonderful organization of Tamil Nadu. Thank you for having me here. It's a great thing to come from North India to Tamil Nadu. And, and I think the best thing to have happened during COVID was these webinars, which has brought us all together. And thank you for continuing with this all the time, because it's become easy to travel like this, not travel like Sampath is traveling from one part of the country to another, but she has her own reason, and we all wish her all the best, and we want to see her at the top then. So coming back to this webinar, I think, like Kalpana has said, Blossom is a wonderful name because we are always wanting our patients to blossom. And we always want that success to happen to them whenever we are dealing with infertility patients. So this is a very apt name. I congratulate you for that, Kalpana. And of course, the two topics that you have chosen, very thoughtfully chosen. IUI is something which is a household name now for all gynecologists who are practicing infertility. But more than that, what we need to understand is that it is now licensed. We cannot practice IUI unless we are licensed under the ART Act, and only level 1 practitioners can undertake this procedure. So we have to know that. I'm sure Sunita is going to deal with that as well. And then you have jumped to embryology, which is for level 2. So I really think that you have very thoughtfully thought of the two topics today. One is for the level 1 and the other one is for level 2. But that doesn't mean that the gynecologists who are here with us and, they are not level 2 should not know about embryology, because they are the ones who are actually the first line of contact or the first responder for any patient who comes, So all general gynecologists must know what is happening in the embryology lab, what is happening in the IUI lab, and how we go about practicing all these procedures so that they can also give a better outcome and refer their patients to the right person. Most importantly, refer their patients to the right person so that, people don't waste time and they don't go. We are noticing, Sunita knows, and all the others who are doing IVF know that there is a lot of IVF failure now. And how do we prevent that from happening is when we know our subject well and we treat our patients properly. So I think, Kalpana, congrats to you for this wonderful webinar and the two topics that you have selected. Very thoughtfully done. And I look forward to listening to all the participants now, all the panelists, and of course the two moderators who are going to, take us through all this. So thank you very much for having me here. I'm here listening to all this. Thank you so much.
Thank you so much for your blessings. When I took over as Foxy Infertility Committee Chairperson, the first thing was to have a conversation with the previous chairs. And I had discussed with Sonia Malik ma'am, and she told online program she used to conduct from her hospital to various other consultant hospitals through online programs. So we are just following all those your advice. Thank you so much.
Thank you so much. Thank you very much.
Understanding why IUI cycles fail is often more valuable than merely knowing how to perform the procedure. Today, our speaker will guide us through the real-world challenges encountered in IUI practice, and over to Dr. Sunita Arora, ma'am, for your session.
1 minute, Safrin, you have to invite Shanta Devi, ma'am.
Yes, ma'am.
Secretary of
Yes, ma'am.
will invite
It's my-
our guest of honor, Sampath Kumar.
Yes, ma'am. It's my honor to introduce Dr. Shanta Devi, ma'am. She's a former professor of Madurai Medical College and past president Teni OG Society. And her areas of interest are high-risk pregnancy and critical care in obstetrics. And she has been association with FOXI, ISAR, ICOG, and IAGE. Welcome, ma'am. Welcome, Shanta Devi, ma'am.
Good evening, everyone. I thank Dr. Kalpana, the FOXI Chairperson Infertility Committee, for conducting this weekly Blossom webinar with a very useful and interesting topics. So the Blossom name is appreciated by everyone every week. I'm extremely honored and very happy to introduce our great Tamil Nadu Singapen, Professor Dr. Sampath Kumari. She is very well known to everyone all over country, and but I have to introduce that she is the FOXI Vice President 2022 and past Vice President FOXI. She is a Senate member of Tamil Nadu at MGR University and National Corresponding Editor, Journal OG of India, that is Jogi, and Founder Secretary Tamil Nadu Federation of OG. That is, she has taken all the efforts to start TNFOG. I know how how hard she works. As Sonia Malik Madam said, that is a Sampath means it's a hard working. Really, it is apt. That is, she has appreciated your work. And most importantly, she is the candidate for post of FOXI President election year 2026. I wish you all success, Madam. And over to you, Madam, for your blessings.
Thank you, Dr. Shanta, and I thank Dr. Kalpana and Dr. Shanta Devi for this inviting me for the wonderful Blossom program as a guest of honor with Dr. Sonia Malik Madam, who is the Dean of Infertility. Anyway, the topic she has taken, really it was I practice infertility only up to IUI. After attending Kalpana's and Shanta Madam's Blossom classes, I think I should also go for infertility at this age. I think it's really always they take one topic as an as Madam was telling, which can be done by everyone, and the second topic which we cannot do, only with the help of others. So it was really nice. We have the wonderful chief guest, Sonia Malik Madam. When I went to Delhi, I tortured her. I went to her place and I saw her in the Nova Infertility Center. Anyway, I am contesting for FOXI President. All of you, please vote for me. Now you have the wonderful topic, Troubleshooting IUI, moderated by Dr. Sunita Arora, and the panelists being Dr. Anuradha, Dr. Sukita, Dr. Madhu, Dr. Sudhir, Dr. Chika, Dr. Arun, Dr. Sharada, and Dr. Shobina Khan. See, whenever we do the IUI, we know what is the reason for the failure and how we can change the protocol and how the other next cycle can be made success. I think after the Sunita Arora's talk, everyone will be having a good take-home message. And the second topic being by Dr. Charulata Chatterjee, with the panelists or experts, Dr. Nishant, Dr. Sudhasini, Dr. Fari, Dr. Muhammad, Dr. Nidhi, Dr. Sindhuja, and Dr. Gaurav. So I think we have many people who are all doing the infertility practice. They will have a good knowledge from that Dr. Charulata about the embryo inside, how the outcome can be good. So I thank Dr. Kalpana and the faculties, Sunita, Charulata, and entire panelist for having the wonderful Blossom. As she told, the Blossom is just to grow up. So everyone will have a good take-home message. I am a humble request to all of you. I am contesting for FOXI President election year 2026. The election timing is August 1 to 20. All of you, please vote for me. After a long time, I think after 37 years, we are contesting from Tamil Nadu. So that I think you should give me an opportunity to, and we will have a good work from adolescent to menopause. Thank you, Dr. Kalpana and Dr. Shanta. Sonia Madam, thank you so much for the nice words. I'm traveling till August 10th. We have to travel. Thank you. After that, also with good results, I think we will be going to the places to thank everyone. Thank you. Thank you, Kalpana.
Thank you so much, ma'am. Wish to see
All
you.
the best wishes for Kalpana doing this Blossom webinar every week with a wonderful selection of the topics. Thank you, Kalpana.
Sampath Madam, I wish you to introduce as President-elect after
Yes,
August.
definitely, Shanta Madam. With all the supports, we can do
Sure,
it.
sure.
Saffron, introduce Dr. Sunita. Saffron?
She's muted, I think, Kalpana.
I request Humaira ma'am to introduce Sunita ma'am.
Okay, I will introduce Sunita. Sunita is a dynamic member of Foxy Infertility Committee, doing lots of work in our committee. I think she is also past chairperson of Delhi, sir, if I remember correctly. So she has got fellowship in reproductive medicine and also done her training in New York, and she has got a rich experience of almost 23 years of experience in the field of reproductive medicine, and she's heading the department at Fortis and various other hospitals also, GK2.
Thank you, Dr.
Past
Kalpana.
president,
Thank you for the introduction. I think I will start inviting the panelists. Let's start inviting the panelists. Anybody is doing this?
you can invite Dr. Sunita.
So let me share my screen, please.
We can have a short introduction of the panelists. Do you have it in your presentation, or we will introduce can you please, Sahiti, can you please run the slides? We have Dr. Anuradha Surita Kareem, who is ART specialist, laparoscopic surgeon, Star Hospital, Safal Test Tube Baby from Gorakhpur. And we have Dr. Madhu Gulati, fertility consultant, laparoscopic surgeon. She is from Eastern Uttar Pradesh, currently director of.
I'm also from Gorakhpur, ma'am. You don't have to go into the details.
Yeah, because your CV is too big to look into it. She's a fertility consultant from Gorakhpur, Dr. Sudhir Gupta. Again from associate professor from Gorakhpur, director Greenland Hospital. Welcome, Dr. Sudhir.
Good evening to everyone, ma'am.
Yeah. We have next panelist, Dr. Shika Tandon, who is director, Matruva Fertility Center, Gorakhpur, with rich experience, almost 12 plus years of experience in the field of reproductive medicine. And Dr. Arun Kumar Singh, who had done fellowship in reproductive medicine and also cosmetic gynecology, director, Pratiksha Fertility IVF Clinic, Balasur, Odisha. Welcome, Dr. Arun. Dr. Sharda Maheshwari, fertility consultant.
Good evening, ma'am. I am IVF specialist.
From Ayodhya.
Bareilly. In Bareilly, ma'am.
Bareilly. Dr. Professor Shabna Khan, who is from Bangalore. Welcome, panelist. Yeah.
Can I share the screen now?
Yeah. Sorry, Sunita, for the delay.
No problem. Actually, I didn't have CV slides of panelists, so thank you for introducing everyone. Is my screen visible?
Yeah. Make it full screen.
Yes.
Yes, I'm going to make it full screen. So at the very outset, I would like to thank Dr. Kalpana and Team Tapisar, and thanks to Dr. Sonia Malik ma'am, chief guest for the today's event, for being there, Dr. Sampath, and we had Dr. Another person whose name I'm sorry I'm forgetting, who is guest of honor for today's event. So thank you for having me here. And the topic which is given to me by Dr. Kalpana is troubleshooting in IUI. And all of us who are practicing fertility, IVF, Dr. Sonia Malik, if she is there, she will also agree with me that when our patients conceive in IUI, it makes us more happy than, doing IVF and making them conceive. So IUI, we all know that it allows deposition of good number of highly motile sperms in uterus near the fundus at the time of anticipated ovulation in the women with at least one. There is some disturbance in the background.
Sahiti, can you please mute others? Other than panelist and moderator, can you please mute? Yeah.
So with at least one patent functional tube, and the time of insemination should be as close to the ovulatory window as possible. Now, as far as indications are concerned, all of us are very well aware. This is just to, show you the list for the benefit of my audience. So the factors which usually go towards IOI, the indications, most of the time it is unexplained infertility, mild male factor infertility, sometimes anovulation, sometimes cervical factors, mild or minimal endometriosis. Then, one functional tube, our bent of mind is towards IUI, then psychosexual, and the contraindications being cervical atresia, cervicitis, we have to treat it first before going on to IUI, bilateral tubal block, severe oligospermia, and severe endometriosis is a relative contraindication. So these particular points, if we see, we all know that IUI is not a very high success rate procedure. So maximum 18 to 20% chance in bestest of scenario when we have two beautiful follicles and timely done IUI, husband sample is good pelvis without any adhesions or anything. Then also we are touching 18 to 20% maximum. So these are the points, if we master them, like if we know indication, when to do, when not to do is also equally important. We know our stimulation protocols well, as far as IUI is concerned, then criteria, how to monitor, when to trigger, how to time IUI, whether double IUI is going to give any benefit, does semen preparation technique, if it is done differently, can give better success rate, then insemination technique, whether at all any luteal support is required, and when to cancel and quit and move on to IVF. So if we master these points, so actually we are done, like that is the time when we say that, yes, I have rightly done IUI for my patient. And the success rate we can take maximum, as I said, towards 18 to 20%. So with this background, let's move on to our first case, which is a very simple case scenario, which we usually get in our OPDs. 27-year-old female married for 3 years with young husband around 30 years, primary infertility, normal BMI, husband semen analysis normal, bilateral tubes open, patent on HSG. She has history of ovulation induction with timed intercourse, 2 cycles, and ovulation was documented both the times, but no IUIs have been done before. Her baseline ultrasound shows intral follicle count of 10 on one side and 8 on other side. So let's start with our panelist. Dr. Anuradha, can we start with you? How will you go about this case? She has done 2 cycles of OI with timed intercourse, and now she has come to you for an advice. Dr. Anuradha is there? Can we go on to Dr. Suretha? Anybody who wants to answer, please, from the
Ma'am,
panelists?
she's a young patient. She's 27 years old and her AFC is good. She's married for 3 years and she's started taking ovulation induction just 2 months before. So she's obviously a very good patient for IUI. Bilateral tubes are open, semen analysis is good. So in this patient, we can go for IUI with an induction starting with Letrose. Because the AFC is good, so probably by Letrose only we can get more than 1 good follicles. We'll start doing follicular
Can you
monitoring.
just enumerate the basic investigations which we should be doing for cases of IUI? Because sometimes we have seen that people skipping even the most important ones. So can you just enumerate some investigations which we should be doing?
Complete blood count, blood sugar, and HbA1c, then thyroid and prolactin levels. HSG is already done, semen analysis is done, then the viral markers and VDRL and thalassemia trait.
What about
These are the basic.
rubella? Do you check your patient when they are coming for a preconception counseling if they are immune or not immune?
We have to.
We are checking sometimes, like recently the guidelines have changed. Now they are saying even after 28 days. Previously, the time period after rubella vaccination was 3 months. But now a few vaccination companies are saying, I'm not very sure, but they are saying that now the time is less. Now it is only 28 days. Means like preconception, whenever we are giving this rubella vaccine, after 1 month we can start.
That's altogether a different thing. But are you testing routinely the IgG levels
we are
for
giving,
rubella?
We are giving
Dr.
that
Sudhir,
vaccination.
Dr. Sudhir wants to say something.
Yes, ma'am. Yes, regularly I ask for the rubella because sometimes after test, if rubella is positive, we are in the disease condition, what to do. So if we test for the rubella, if antibody is good, more than 10, nothing to bother. If less, then we give the RVAC, and after 1 month we can start IUI or whatever the ovulation induction.
Yeah, correct. So the interval, as already mentioned, is 4 weeks after the vaccine. Dr. Shabina, are you routinely doing husband semen analysis or you leave it for the day of IUI for your patients whom you are taking
No, we are
for
routinely
IUI?
doing. We are doing.
Yeah, so that's the right way. And are we doing semen culture also for all?
No.
No. So unless
No, ma'am,
the
no.
semen sample says pus cells, we are not routinely doing. It looks like a simple case, and she has just tried ovulation induction and timed intercourse. So routinely, it is not advisable always to go for semen culture unless there are a lot of pus cells, more than 5 to 6 pus cells also. Then also you should go on for semen culture. So you advised IUI for this patient. So now my question to Dr. Madhu. Dr. Madhu is there. Dr. Madhu, do you advise a scan on day 2 for all your patients, or you start ovulation induction and you skip day 2?
I always do a day 2 scan. जाओ इसको भेजो, रवि को भेजो. I'm sorry, I don't know. I think there is some problem. Can you hear me?
We can hear you, ma'am. We can hear you.
Yeah, I always do a day 2 scan. I never skip it. And the drug of choice, it depends if it is PCOS, PMOS patient, lot of follicles, then I prefer letrozole. And sometimes I use clomiphene citrate. It depends on, the ovaries and the AMH and the ovarian profile which I see.
So the next question, Dr.
I
Shabina,
use
are
both.
you
I use both the drugs,
right,
letrozole
ma'am?
also and clomiphene.
So, Dr. Shabina, are you routinely doing
I
AMH
repeat in
as
ultrasound
Dr. Madhu
after,
just mentioned?
after 5 weeks.
We are routinely doing in
All cases of IUI, you are doing AMH with this kind of a patient who has 10 follicles on one side, 8 on other side. Dr. Sudeep, will you differ in opinion?
Yes, ma'am. Because nowadays we go for the AFC count. If AFC is good, nothing to bother about the AMH level. And because most of the time we monitor the patient. So yes, definitely AMH should be done to know the ovarian, but not routinely. Once we have the AMH level and AFC count is good, we give more emphasis on the AFC.
Right. So in this kind of a scenario where the follicle count is looking perfect, it's a young couple and patient, like you want to save some money for the girl, you can avoid it.
Yes.
There is nothing like mandatory to do AMH for such cases,
Yeah.
but if the follicular count is looking less, you feel this lady may qualify as a case of poor ovarian reserve, and she is on higher side of age, then it is always better to do AMH and then go forward. So, Dr. Shikha, can we come to Dr. Shikha? So we started with clomiphene citrate 50 milligram for this girl for 5 days. And on day 9, there was no response. All follicles were 2 to 3 millimeter both sides. Then she was called on day 12 without any addition of drugs. Then day 15. So there was no response. So would you manage this case differently? Like if, this particular slide says patient came on day 9, there was no response. So will you do something on day 9, or you will, just like I called her on day 12. So will you be doing the same thing, or you will try to add something, change something here?
Ma'am,
Dr. Shikha, yeah.
hello.
Yeah, please.
Ma'am, on day 9, we may increase the dose of CC to 100 milligram and call the patient after 5 days. Or second option, maybe we may shift to Letros because patient is not responding to CC.
So on day 9, you will shift to Letros?
No. In another cycle, in next cycle, I'll start with Letros.
So on day 9, yeah, Dr. Shabina.
We can add gonadotropins.
I somehow don't believe in mixing both the drugs, clomiphene and Letros.
And you can add.
And I would prefer shifting the patient on gonadotropins.
Yes.
So shifting on gonadotropin.
Yes.
I think most of the people will agree. If there is no response, then we should be adding gonadotropin in such cases. Anybody differs in the opinion here on day 9? We don't find any growth.
No, ma'am. No, good. Because after adding HMG, yes, definitely we get a better follicle. Yes.
Dr. Arun?
Suppose, hello, madam. Yes, ma'am. Suppose I give letrozole or clomiphene for 5 days. Next day, I call them. If there is no dominant follicle, I start continuous gonadotropin HMG 75 milligram till I get a dominant follicle, maybe 15-16 millimeter.
Okay, so how frequently you will be calling when you put your patient on gonadotropin?
No, if I am giving 75, I call almost every 3-4 days. I give 3 doses of gonadotropin, then I call and I see the response of the follicle.
Okay, doctor, tell me one
thing.
thing. If the patient is non-affording, she doesn't want to take gonadotropin and you are dropping this cycle, then what would be the change in your next cycle?
Next cycle, we can start with clomiphene 100 milligram because it has given 50 milligram, 100 milligram I can give, and I can start with all intermittent gonadotropins. Suppose day 5, day 7 or day 9, like that also, because that will reduce the cost of the cycle.
And you can shift to letrozole also, since she did not have a response with CC50. If she doesn't want
letrozole, we can shift to letrozole also.
All right.
With gonadotropin.
Yeah. So Dr. Shraddha, is Dr. Shraddha here?
Yes,
yeah.
ma'am.
So this patient was started on gonadotropin, and after 5 days, because there was no response. So how do you generally decide which gonadotropin, and what is your dose of starting gonadotropin in such patients?
Because her age is 27 and AFC is good, so my starting dose will be 75 into IU of HMG, human menopausal gonadotropin, in this patient.
For how many days?
For 3 days I'll give, and then call the patient on 4th day, see whether the follicles are increasing or not. Sometimes in some patient, even the patient won't respond to gonadotropins also. So then after 3 days, if the follicle is increasing properly, I'll continue with the same dose of 75, or I may increase the dose to 100 also, depending on the response of the patient on follicular study.
Yeah, so the point which is to be noticed here is that when you start your patient on gonadotropin, you can't just leave her alone for 5-6 days. You should call her and look at the response, because sometimes the response can be too florid also. So it's not about the increase in number of follicles which we are looking at. We are looking at getting the dominant follicles here. So out of all the various regimens which are available for using in cases where we are taking patients for IUI, anybody who prefers some other way to add gonadotropin? Anybody wants to give any opinion? Dr. Shabina, Dr. Arun, or this is your preferred way?
Generally, young
Ma'am,
patient would
I actually, ma'am, always do a combined.
Chronic low-dose step-up regime.
I always give with letrozole and gonadotropin or
Yes.
clomiphene with gonadotropin, because that will reduce
right.
the cost of the cycle.
So that's a sequential regime.
So maximum
Dr.
give
Madhu
for
ma'am?
gonadotropins, maximum patients will have a dominant follicle.
Dr. Madhu ma'am, you were saying something?
No, I also do the same. Start with either clomiphene or letrozole, and then add gonadotropins if they're not responding well.
Right.
I normally
So-
give FSH 3 or 4 injections, and then once it's around 14, then I shift to HMG.
All right, ma'am. So there are so many regimes which are mentioned in literature, but this is the most preferred one by most of us. Reason being, you reduce the cost, you increase the chances, you increase the success rate. It is easier and less frequent monitoring, at least initially. And I personally feel you will have a chance to see and assess how your patient responds. Like you have time windows. Like first you're putting the patient on oral drugs. So sequential use of CC and HMG or FSH. Higher pregnancy rates are seen than with CC alone, more cost effective, lesser multiple pregnancy rates, and lower incidence of OHSS. And how it is done, just for the benefit of my audience, you can start either with 50 or 100 milligram of CC, or you can start with letrozole for 5 days. And then you call your patient, assess. If there is no dominant follicle yet, then you add gonadotropin. You can add 75 HMG. I usually do it for 2 days and then call my patient. And then, you have a better assessment. Does the patient need more doses, or a follicle is already recruited? Sometimes when the endometrium is lagging behind a lot, I don't give further doses and I start focusing on endometrium. This is how, because otherwise sometimes the follicle shoots up, endometrium lags behind a lot. So give additional dose if adequate size is not reached, and HCG once your follicle is around 18 to 20 ml. On the other hand, if you're starting gonadotropin right from beginning, Dr. Shraddha, can you tell me how, suppose your patient does not respond at all to the sequential regime, to CC, to increase letrozole, to increase CC doses, and you plan to start right from beginning the gonadotropin, then how do you go about it?
I generally start with 75 IU of HMG for 5 days and then call the patient on day 6. Assess the size. If I'm getting a dominant follicle, then I continue the same days for 2 to 3 more days. Or if the follicle is not dominant, like follicle is less than 14, then I sometimes increase the dose by 25, that is 100 IU.
So the catch here is that never start too high a dose for patients whom you are targeting for IUI, because you cannot go back, right? So once too many follicles are recruited, then you either have to maybe canceling or maybe converting it to IVF. So that's why we have to be very cautious. Dr. Madhu ma'am was mentioning about chronic low dose protocol. Ma'am, do you want to say something about it? Do you use it in your practice?
I don't.
You don't? Okay. So I have used this in severe PCO cases once in a while where patient, is not responding to anything. And believe me, it needs a lot of patience, but it works very well. So you start with a very low dose,
Yes,
37.5 to 75 international unit, and don't touch your patient for 7 to 14 days. And then you call in around 7-10 days and look at the response, and you can keep on increasing the dose by 37.5 per week. Maximum you can go till 225. So because it needs more number of days, it is for really resistant PCOS, it can work well. So we should know that this something like this also exists and can be done. But step down protocol for IUI, like starting with a higher dose, then you have to know your patient well. If her AMH or AFC, we should say, because we didn't do AMH for this patient. If the AFC is on higher side and I start her on 150, there may be a very florid response and maybe too many follicles getting recruited. That's why this is not a very preferred kind of a protocol. But definitely when we compare gonadotropin with CC or gonadotropin with letrozole, the comparison shows the chances of pregnancy rates are better with gonadotropins and there is higher success rate. So Dr. Shraddha, what is your follicular size when you feel that now the trigger should be given, when you are doing it with oral drugs or when you are doing it with gonadotropins? So can you just tell me about that.
When I am giving only oral drugs like either clomiphene or letrose, then my size is around 20 to 22 mm. But whenever I am adding gonadotropin or it is only gonadotropin cycle, the size is 18 mm. And I also do the color Doppler on that day to see whether the peripheral vascularity of the follicle and the thickness of endometrium, the pattern of endometrium, the viscolarity of endometrium. And according to that, I decide the time of trigger.
I think very, very clear message that oral drugs, you need to go little longer, 20 to 22 mm around. And for your gonadotropin cycle, around 18 mm is a good size. Then the timing of insemination is very important, right? So all of us are very careful and most of us are choosing ultrasound as the modality. Anybody using LH surge or LH levels to decide on when to do IUI?
Yes, ma'am. I routinely
For confirmation
do
of
LH, urine LH. So because sometimes we get premature LH surge also, sometimes it can predict. So one patient last cycle I was doing at 16 mm, that LH surge came positive. So I call her next day, follicle ruptured, and I did the IUI next day.
So are you doing it routinely for all IUI cases?
I almost routinely do in all IUI cases after the follicle reaches 16 millimeter. Twice I do, morning and evening. So suppose I decide I am giving, because I give a combined regimen. So when my follicle is maximum 20 millimeter, I give a trigger. 18 to 20, I will give a trigger. So before giving trigger, I do LH surge to see whether there is a premature LH surge. I do the urine LH. If it is not there, then at 20, I give the trigger.
All right. So I am not doing routinely the LH and I'm monitoring my patients on ultrasound only. But I think it's a good practice, little cumbersome for the patient, but it is definitely going to help. So now coming to the documentation of ovulation, Dr. Shabina, you've taken your patient on the table for IUI and now you see that the follicle is not ruptured. So do you always document rupture and then do, or you feel that once we have given the trigger, we should go ahead and do IUI?
No, actually, if it is not ruptured, then maybe I will think we have to take a consent or we have to document. And without rupturing, I never do IUI.
Dr. Shraddha?
Because I'm always testing.
I will do IUI. I'll do one that LH kit test also, just to check whether that I'm getting that LH surge or not.
That only.
Dr. Suritha, Dr. Anuradha? They are there, Dr. Anuradha and Dr. Suritha. Dr. Arun?
Ma'am, what I do, earlier I was always checking the ovulation by ultrasound, but I saw a lot of patients were not ovulating on that 36 to 40 hours window. So I left that idea and I went through the literature. It has been showing that within 24 to 40 hours of SCG, you can do IUI at any time. So what I do, at 36 to 40 hours, I do a IUI irrespective of the follicle has ruptured or not. And if the follicle has not been ruptured by the time of IUI, I call the patient again next day to see whether it is ruptured or not. If it has been ruptured, then it's okay. It is not ruptured and this sample was oligospermia, then I can think of a second IUI in those cases.
Yeah, I
That is
totally
my
agree
practice.
with you. So this is how I also do, because 36 to 40 hours later, suppose the follicle ruptures at 42 hours, you can't keep on doing this. But it is very convincing when you document ovulation, and literature does say if you document and do, it may give you marginally higher success rate. But in a patient who has a history of repeatedly not rupturing the follicle, there it becomes very important. So like some case of endometriosis who makes a very good follicle, but the history is the follicle doesn't rupture. So in that case, I'll be very skeptical and will not be doing, and I may call her next day only because, it's kind of it's a procedure. And especially when we are working in corporate hospitals, IUI also, it's like 20,000 in Fortis where I'm working. So yes, we have to sometimes think for these kind of cases who have history of luteinized unruptured follicle, or who do not rupture follicles in IUI cycles in spite of maybe even a booster trigger. So there we have to be really careful. So now let's go to Dr. Madhu ma'am. So we are sitting in a clinic and my gynec friend calls me up. There is a 30-year-old lady, primary infertility and frank PCO on ultrasound, BMI being 27, she's on metformin, antral follicle count 15 to 20 on each side. There is no other factor and she's not responding to letrozole, conventional protocol, to CC, and what else I have written, it's hidden, and even to the extended protocol for letrozole, she is not responding. So your friends, they call up, no, PCOK is not responding to anything. So Dr. Shraddha, Dr. Madhu ma'am, how will you go ahead managing this case? Will you tell her, send her to me, I will manage, or you will suggest her something?
First of all, though, I'll tell her to make some lifestyle modifications for 2 to 3 months. I'll add some adjuvants also and weight loss. And in fact, so many times the patient is lean and thin, but the patient is having PCOD. In particularly those patients also, these lifestyle modifications works a lot better. And I'll call that patient after 2 to 3 months. And on the very first cycle, I'll start with extended letrozole protocol. The patient may respond now if patient has followed the lifestyle modifications in a proper way, or I may start with chronic low dose step-up protocol of gonadotropins in such patients.
All right. Dr. Shikha is there? Dr.
I would
Shikha?
see her LH also, because in PCOS, sometimes you get very high LH levels. So I'd like to put her on OCPs for 2-3 months and to bring the LH down. And sometimes that works very well also. So sometimes then you, like if too many follicles, very large ovaries, there's a debate also whether to do ovarian drilling these days or not. But earlier we used to do a lot of ovarian drilling and get good results. But sometimes now it is, you go in for IVF, save the, you collect a lot of oocytes, a lot of embryos, you use them in 2 cycles, 3 cycles. So it all depends upon who is doing what and what the patient can afford, what the patient wants. Sometimes you are in a dilemma, you've given about 8-10 injections and then you still, the patient. I had one patient like this. Husband had come down from Bangalore and he had to go back. The deadline was 1st of June, and she didn't, after 8 injections also not
responding to
the follicle size could not happen. So I just left it. I told the husband, you go back, but I called her today, and today it was, 18 mm. So, like at times you really don't know what is happening.
But ma'am, so many times
is so complex.
IVF in such
anybody-
PCOS patients won't respond to IVF also. Like after 7-8 injections of
Yes,
gonadotropin,
so
we
then
see that
in
the
that case, will you go for laparoscopic drilling if she is not responding in
Yeah.
IVF? So once in
Yeah,
a while,
yeah.
yes, we can think of, but yes, as Dr. Madhu ma'am just said, that laparoscopic ovarian drilling has really lost its, original charm it used to carry, and now most of the time we convert such patients to IVF. And anybody has any experience of adding mild steroid to these cases if they are not responding?
Yes, ma'am.
I-
Yes,
I-
ma'am.
androgen
I-
levels
I-
are high.
We should say
I
yes.
started
You have
adding
not
steroids.
mentioned regarding that hirsutism is there or not. What is the hyperandrogenism profile of
Yes.
that patient? So sometimes
Right.
if it is there, we can add just dexamethasone 0.5 milligram from day 2 to till
Day 10.
around 10 days. Yeah.
Okay, so now we come to another case, 31-year-old female, known case of PCO, started on Letroz 5 milligram, followed by HMG 75 for 3 days. I didn't see her for the last 9-10 days, and then I call her on day 10 straight, like I've written Letroz for 5 days, followed by HMG, and now there are 8 dominant follicles, 15 mm 4 follicles, 16 mm, 17 mm 3 follicles. So what went wrong here? Basically, I put this case just to keep my audience informed that there is a need of monitoring.
Monitoring.
So
In this particular case, we have not followed the case.
yes.
Directly, the patient is coming on day 10, which is
Right.
not correct.
Yes. So whenever you are starting your patient on gonadotropins, have a look at the follicles and then try starting, because IUI is supposed to be a very low risk procedure. We should not be giving any kind of complications to our patients who are, it's an OPD procedure, should not be getting converted to a complicated thing. How frequently we call, I think we partly discussed this, but what is the criteria for cycle cancellation in IUI cycle if there are too many follicles? How exactly, Dr. Shabina, you go about it, telling your patient that we cannot go ahead for IUI?
Suppose if the estrogen level is, estradiol level is high, and we are going
How
to
high?
high means more than 900 to 1400 pg per ml. And if
Okay.
we are seeing the dominant follicle, or it is more than 4 to 6. If the size is 16 mm, something like that, 15, 16 mm.
So
If it is
your
more than
cutoff
18,
to cancel is more than 4 to 6 dominant follicles?
yeah, and if it is more than
More
more than 3, size is more than 15. We have to
Yeah, so
cancel.
too many intermediates or more than 3 dominant follicles, ideally we should not be going ahead. But tell me one thing, like in IVF cases, when there are too many follicles, in PCO cases, we give agonist trigger. So do you
Yes.
feel in such cases, if we give agonist trigger, we can get away not having OHSS? Are you routinely using for those cases? Suppose I have 5 dominant follicles. So do you think if you use agonist
Size
trigger,
is more than
yeah, 5
See,
follicles,
Yes.
17 to 18 mm. And patient is saying, I want IUI. Will you give her agonist trigger?
obviously we
We
can
can
give, but
give,
I have
madam,
not done.
agonist trigger, but we have to counsel the patient
can do.
regarding OHSS, because even
And-
after giving
and-
agonist trigger, the patient can develop
And
OHSS.
multiple
And
pregnancy.
even if she
Multiple
becomes
pregnancy.
pregnant, then it will be more dangerous. The OHSS
Right.
will be
Yes.
more severe.
Yeah, so I
So
want
that
to
thing we
bring
have
your
to counsel.
attention to the multiple papers which are there in literature, which say that, which have talked about agonist as a trigger in IUI, but they did not talk about agonist as a trigger when there are too many follicles, right? So here also it carries the same risk. Patient can go in OHSS. So don't think that if you give agonist trigger, because it's IUI, you cannot freeze your embryos, right? So it is, your plan is to make the patient pregnant in the same cycle. So patient will have multiple pregnancy, can have severe OHSS also. But otherwise, if you compare agonist trigger with HCG trigger, the literature says for patients, who have optimum number of follicles, you can use that trigger as well. So now I'm taking my patient for IUI and I'm not able to negotiate the cervix. So Dr. Sudhir is there? Dr. Sudhir? Dr. Sudhir, Dr. Shikha? Otherwise, I'll go to Dr. Shraddha only. Yeah, Dr. Shraddha.
I would like to say something
Right.
because I am based in Gorakhpur and we get a lot of tubercular patients. So the protocol I always follow, I always do a day 2 endometrial biopsy. So for PCR and when I do a endometrial biopsy for PCR, we come to know it's a difficult, it's easily negotiable. We have basic.
I am doing my IUIs under ultrasound guidance. So in the patient in which I am getting an acutely anteverted or acutely retroverted uterus, so in such patients, I try to do a mock IUI on day 2 or day 3. And in otherwise normal patient, I generally don't do that mock IUI. I will try to keep the partially filled bladder, slight head low position to keep the endometrial canal straight. And even then, if I am not able to negotiate the internal loss, then I'll try to use the tenacolum to hold the cervix to straighten the canal and then do the IUI.
All right, Dr. Shabina.
And in
Dr.
rare of the rare cases, I may.
See, once we are holding the cervix with the Ellis, we should not lock it actually. Just we have to pull so
network
that
issues
the
at,
cervical length should come straight. Moreover, whatever madam has said, partially filling the bladder, using ultrasound, and using I think rigid cannula can also help in the IUI. That can also be
So
done.
if we have luxury of using ultrasound in our IUI place where we are doing IUI, nothing like it. Yes, definitely. I'm also doing, under ultrasound guidance. But yes, there are so many people who are not having the ultrasound facility where they are doing IUI. So first thing is you make the bladder partly full, look at the direction of the cervical canal and the uterus. Try to make the uterus straight by partly filling the bladder, use ultrasound, use the rigid cannula. Even after, the first 2 points, if you're not able to negotiate, there is a very beautiful metallic rigid cannula which is available for IUI. And most of the times you will be able to get away by
Plastic
not.
also
And
available nowadays.
sometimes, yeah.
And mock
Rigid
And then
catheters are available.
sometimes by using 2 sim speculum, like you can actually you can adjust the axis. So I'm using 2 sim speculum for retracting upper vaginal and lower vaginal wall. So you can kind of straighten the axis. Try that. And holding the cervix is my last priority. Most of the times, if you have a metallic cannula, and also one more thing, if you are working at IVF center, you have ET catheters. And I'm sure once in a while, all of us are using this for difficult cases. And it's a very thin, flexible catheter, which we use for embryo transfer. And I think 99% of the times, we don't need to use anything else. So that is for the difficult cases of IUI on table. And as Dr. Madhu ma'am mentioned that she's doing endometrial biopsy for all, it being that kind of a region where the tuberculosis is prevalent. It's prevalent all over India actually. So that's a very good practice, I feel. Then coming to, we discussed that unruptured follicle in previous 2 consecutive IUI cycles. So how many of us are giving a booster dose? The follicle is not ruptured. So let me give her another HCG or let me give her agonist. How many of us are doing that?
Sometimes giving a booster dose.
Sometimes I give madam agonist trigger if it fails to SCG. Or sometimes I have given agonist trigger. And to my surprise, I also got pregnant in that cycle, 2 patients.
I've never used an agonist actually, so I think I should try
once
it.
Once we use agonist trigger, we must increase our luteal phase support.
Luteal support.
Okay, fine.
That is the
So
thing.
I have done
maybe next cycle
4 consecutive IUIs. My patient is not ovulating at all. I am documenting every time that ovulation not happening, not happening, not happening. Now what should I do?
We should look for the pelvic adhesions.
No, we have to see LUF. It is luteinized unruptured follicle. That endometriosis should be kept in mind.
Right, but now what is the way forward?
No,
so you will
we have to investigate her. Why there is LUF? So
Give
all
her
the
a
We
causes
should
of
go for a
uterine
diagnostic
and
laparoscopy.
ruptured follicle
Suppose
should be
she
kept
has
in mind.
symptoms suggestive of mild endometriosis, but she has persistent luteinized unruptured follicle, then what do we do? Do we
Give
do
her a trigger
laparoscopy?
at 16 or 17. Give her a trigger earlier. Don't wait till 18 or 19 or what. No, give her a
All
trigger.
right. So
earlier.
if there is a repeated history, such history,
Diagnostic
then you
lab
may
can be
need to
done.
take these patients for IVF, right? So this is what I'm trying
Yeah.
to say. Now let's see a case of male fertility where there is a young couple, but the infertility duration is 7 years. Husband's sperm count is 1.5 to 3 millions in all past reports. Motility is around 30%. Female partner is absolutely normal. So will you try IUI for this case?
No, IVF should be advised for her first.
IVF, or you will go for ICSI?
Yeah.
So total motile sperm count more than 5 million minimum is
required for
the
her.
requirement. Otherwise, most of the times our success rates are too low to, kind of suggest IUI for this case. Now, this
But madam,
particular person brings his brother to your center and requests you that please take his sperms and don't tell my wife. So can you do
No,
it?
we cannot allow.
never.
No,
No,
never.
not at all.
Never.
Not at all.
So
Never,
how
never.
you should go about it? So like
We have to tell the patient that if he wants his brother's sample, then they have to go to the nearest ART bank, get registered there, and then they can get the sample there, and they can give the sample to the nearest center.
Yes.
right. So basically, nobody can, bring any other person
We should keep
out
eyes, even CCTV and all, who is going inside the room.
out of the wedlock, and if somebody is there to donate or wants donor, so that means a known donor is allowed as per law.
Yes, yes.
No. No.
Yes, ma'am. It
This
is
is a
allowed.
known donor, right? So is known donor allowed as per law?
He has to register first.
Yes, it is.
Register.
But she has
Yes,
to register through
Registered
the
one
ART bank.
maybe
So
known
a known
or
donor
not,
is allowed, but
whatever
the
it is.
route has to be through the donor bank.
Through the door.
So that person
Yes.
has to go to the donor
ART
bank, get
bank.
registered there. ART bank, yes, right. And all the investigations which are to be done for the donor are to be done, and then those samples are to be sent to the IVF center, and then only it can be used. Hanji, ma'am.
I usually counsel the patients about the social, psychological, and emotional,
Right.
problems which will happen very early in my practice. There was a couple, two sisters, and एक husband was Azo. The other sister husband came that हम sample देंगे. When I refused, इतनी मेरे को गाली, इतनी बदवाएं देके गया, because this sister's husband was loaded, very rich.
Ma'am, it happens every other day. Something
I
happens
can't tell
every
you early in my practice, but then I, said, no, this is not possible. It just can't, it's not possible. It's not possible.
Yes, so we have to put our foot down, and now since the law is so strict, so we have to follow the law absolutely, like what is written, what are the recommendations, and all those protocols we have to follow. And ma'am is very right in saying this. I also tell my patient the same thing, that right now you're feeling that it is family genetics which is going to
Later
come,
on.
but later on it is going to create
बाद में बहुत
Yes.
more
होता है.
problems. So I also
More problem.
indirectly counsel my patient not to go for known either egg donor or
Yes.
sperm donor. It's up to them, but yes, by law, if they are properly channelized, you can take them. Now
Ma'am,
this is
by this way also, 6 months quarantine will be required for that family
Yes, yes.
person also. So
absolutely
that is also one factor. We can say even if you want, you have to wait minimum for 6 months for this.
yes,
Right.
yes. So there is a couple who comes on day of IUI, trigger is already given, and male is not able to produce the sample now. And they say they stay half a kilometer away. They request to let them collect the sample at home and come. Will you allow them? Are there any extra precautions? So what do you do in such cases?
Yes,
Yeah, we can allow
can be
them.
allowed. but we have to take a affidavit. If
Yeah.
possible,
Yes.
That the
always
person
take
is
a
getting his
affidavit,
own semen
and both
with his own
husband
handwriting.
and
He has
wife
to write.
should sign in that affidavit.
Yeah, he has
Yes,
to
so
write
you have
his
to be
own.
very careful, because here what can happen is if they are bringing
You can get
somebody else,
somebody
so
else.
now the responsibility should be thrown in the court of
Yes.
towards the patient. They have to sign that it's their own sample, and we take signatures from both husband and wife that this is her husband's sample only. So they have to take that responsibility, and a special consent form and documentation should be done
Yes.
for later also. Like, what we do is in all these kind of cases, we have made special consent forms and documentation, which we are saving for these kind of cases, because this happens once in a while, maybe once in 6 months or 3 months. But yes, then that proper documentation and consent has to be there.
Ma'am, the
So,
time duration is 30 minutes, but in the slide it is mentioned 1 hour. Is it 1 hour?
No. So yeah, going by what literature says is within 1 hour after ejaculation. But yes, it has to be as actually it
Earlier.
is
As
from
possible.
collection to the preparation, ideally should not cross 90 minutes, right? From insemination. But yes, it is written. I also checked it. So it is 1 hour after ejaculation, within that time, and the temperature has to be properly maintained. Now, this is the last case, because we, encounter thin endometrium with good follicles in so many IUI cases. So, can I take this case, Dr. Kalpana? Do you allow us, or should we be winding up? So, okay, quickly. So we have,
we'll stick on to the time, and you can finish that case, I think.
All right. So this is a 31-year-old patient in her first IUI cycle, induction done with clomiphene citrate 50 milligram. On day 9, we find a follicle which is 12 mm with endometrium 5 mm, 999 with good vascularity. On day 12, the follicle is 18, but the endometrium is still 5 mm. Same patient shows you the outside papers of multiple spontaneous cycles monitoring where no ovulation induction was done. And in all those cycles, her endometrium was on, even in natural cycle, was on thinner side between 5.5 to 6 mm. So any additional investigation? First of all, at 5 mm, do you go ahead for IUI? What is your cutoff?
No,
And
we will not go.
Cutoff is 7 mm. So we will not
6
go.
mm, less than 6 mm, I think is good.
okay, but then since this patient has a history of having endometrium towards thinner side in all the cycles, so do you want to do something, investigation, anything?
We want investigation, but it is there ki the endometrium was 999 with good vascularity.
Yeah, so you don't want to do anything?
We can wait, we can go another cycle with letrozole or gonadotropin.
No, we have to
5 mm endometrium, we can wait another 1 to 2 days. There is no harm in waiting another 1 to 2 days.
We can give,
and also we can,
waiting,
if there is triple line endometrium, then we can give the trigger and go for IUI also in the same cycle. 6 millimeter, 6.5 millimeter, also pregnancy can happen. Suppose that cycle she does not get pregnancy, then next cycle we must investigate.
Yeah. So when you are waiting, will you add something here? Will you add something?
We can add sometimes I can add adjuvants like estradiol, I can add at that time, and ecosprin also I can.
I will not add estradiol. I will not add estradiol. I will add sildenafil, arginine, vitamin E.
Estradiol also you can add at 18 millimeter. It is not going to affect
late
the
follicular
follicle.
phase, you can add estrogen. This is
You can
late
add
follicular
estradiol.
phase,
There
you
is no
can
problem.
add, and you should definitely try to look into the cause. And as far as cancelling the cycle is concerned, it is, should IUI be cancelled considering a thin endometrium? So literature says that 6.5 and above, you can go ahead. There is no reason to cancel IUI cycles. Pregnancies have been seen to happen in these cases. But yes, I believe that if there is a persistent thin endometrium and the character is also not good, then definitely you need to go further, maybe testing for infections, testing for tuberculosis, and a hysteroscopy also. So many times your 3D ultrasound will be perfectly normal, and when you put in a hysteroscope, you will find the reasons there, right? So we should go a step beyond, I think. So to conclude, how we can get a better success in our couples when we are taking them for IUI, and how we can all blossom together during IUI cycle, is careful selection of couple analyze your failure before initiating the next cycle. This is very important, which we most of the time don't look back, but it is very important to look at your IUI cycle, what you did in last cycle. Do you need to modify it further? What extra can help this patient? Then low dose HMG based stimulation protocols are giving better success rate. Monitor your cycles always to avoid complications, especially when your patient is on gonadotropin. Sperm preparation, insemination is to be seen as per the sperm quality. If there are a lot of pus cells, double density will help out in such cases. Move to IVF if there are additional factors. So sometimes we see that patient has done 12, 15 IUIs and now they are referred to you for further advice. So timely decisions are also very important. Those patients who do not conceive in first 3 to 4 cycles of IUI, usually IUI is not the answer for them. Move to IVF if additional factors. I already said that. Failure of 3 to 4 gonadotropin stimulated IUI in unexplained or mild male factor is an indication of IVF. And always audit your IUI results. And last but not the least, follow the proper rules and regulations as per the new ART Act. Very important. And we should be, the last 2 years when I was chairperson Delhi SAR, we were spreading this awareness a lot that ART for practicing IUI, how you need to register and all those things. So take help of your friends who are into fertility and who are attached to the IVF or IUI clinics. Take their help and follow proper law if you are practicing IUI in your OPDs. So with this, I thank all my panelists for a wonderful discussion. Thank you so much. Thanks a lot.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Kalpana ma'am, ma'am, over to you, ma'am. Ma'am, shall we move on to second session, ma'am? I welcome Dr. Charulata Chatterjee, ma'am. She's a scientific head and consultant embryologist, and she has a top class experience of last 25 years in the field of ART, and she had accomplishments at ISA, second vice chairman for embryology, ACE past executive member, and faculty speaker participants at various workshops, CME and conference, ma'am. Over to you, ma'am. In this session, ma'am will explore how embryo culture systems, morphological grading, and genetic evaluation complement each other, helping us make more informed decisions and ultimately improve pregnancy and live birth outcomes. Now we welcome our panelist also, Mr. Nishant Singh sir. He is working as a senior embryologist at H Fertility Center. Welcome you, sir. Next panelist, please, ma'am. And we welcome Suhasini Donti, ma'am. She did a PhD in human genetics with over 15 years of experience, and she is currently leading embryology services and regional IVF laboratory operations at Birthright Fertility at Rainbow Hospitals. And she's a chief embryologist and regional head. Then we welcome Dr. Fari Priyanka Saleche, ma'am. And she's also a board of directors at Rotary International Hyderabad Royals and a member of Business International Network. And she's a doctorate and biotechnology and fellowship and clinical embryology. And our next panelist, ma'am, Dr. Mohammad Adkas. He is also a did MS biotechnology and working as IVF lab director, head of embryology, certified in embryo biopsy and ovarian tissue preservation. We welcome you, sir. Then our next panelist, Dr. Nidhi Singh. She's a medical director, Tejasvi Women's Wellness and Maternity Center, ma'am. She's a senior consultant embryologist there also. We welcome you, ma'am. Then our next panelist, Dr. Sindhuja, ma'am. She's a embryology lab manager, Sri Chakra Fertility, Chennai. We welcome you, ma'am. And lastly, we have Dr. Gaurav Mittal, sir. He is a consultant clinical embryologist at Punjab and Chandigarh. We welcome you, sir.
Thank you so much for this opportunity, and we'll start the session because we are already a little late. So I'm sharing my screen now. Just give me a minute. I had some issue here. I
Sure,
should.
madam.
Sorry, I had a very poor net connection. We had wonderful discussion by Dr. Sunita and panelists. Very practical discussion. We really enjoyed it, and we are conducting. Foxy Infertility Committee is conducting a survey on ART regulations. We will share the survey link in the group. Please do fill and give your suggestions too. That will help us to uh, uh, send our views to the national board also. So I welcome Dr. Charlata for wonderful discussion. Over to you, Dr. Charlata.
Just give me a minute. I'm sharing my screen.
Yeah.
Are you able to see the screen?
Yes,
ma'am.
Full screen.
So, welcome all my panelists, and thank you so much after working for complete day and you are here. So, without any further delay, I am starting this because in embryology lab, everything is so important, and it is evidence that we have to, control more than 200 parameters for the successful outcome, and embryo is the most important for the culturing. And we, how do we, culture, what are the things which morphological criteria or morphokinetics or genetics, what we are doing. Welcome panelist. I do not have any, interest in, and I am not promoting any brand or something here, so I'm clear it very well. And we all know that embryo culture has started from 1972, and that time it was an homemade media, but now commercial medias are available. The question one I would like to ask to Gaurav, because Gaurav has a is from the lab and he has to go to the lab. So Gaurav, this question is for you. How do embryo culture media support development? What types of media are commonly used in our embryology lab for culturing the embryo or a gamete, and which do you prefer to achieve the best outcome?
Right. Thank you so much for the lovely introduction, ma'am. Thank you so much to the Foxy team for doing this webinar and giving us this opportunity today. Ma'am, to answer your question, how do culture media support embryo development? So, culture medias are basically solutions that are created to mimic the female reproductive system. So, for example, they have energy substrates, they have essential and non-essential amino acids, they have various growth factors. So all of these combined, they help the embryo to go from a zygote to the blastocyst stage. Coming on to the types of media that are commonly used, we've got the sequential system of media where we refresh the media on day 1, on day 3, and day 5 based on the stage of the embryo culture. So for day 0, for example, we use fertilization media. For day 1 to 3, there's a special cleavage media. For day 4 and 5, it's when the embryo goes into compaction and it's the embryonic genome takes over. That's where we use the blastocyst media. In the initial 3 days, it requires pyruvate and lactate as the energy source. And in the last couple of days, it needs glucose as the energy source. Besides this, the other system of culture media that we commonly use is the single step media, which we can use from day 0 to day 5, and you don't have to change the dishes. This is the media that I prefer personally, ma'am, because it reduces my work as an embryologist. It also reduces the temperature fluctuation, the pH fluctuation, because um, if I take out a dish 5 times throughout a patient's culture, I'm disturbing the temperature, the pH, that many times. And every time there's a risk of the dish falling, me probably not handling the embryos properly. So,
yes.
sorry, go ahead, ma'am.
Yeah, go ahead.
Yeah. So I personally prefer using the single step media, and ideally in a well-resourced lab, I think a single step media along with uh, a time-lapse incubator would be the best combo, wherein you don't even have to open the incubator for per checks or day 3 checks.
Sharing screen you can't see.
Okay, very
That
well
is
said.
what, yeah.
Gaurav, so as you had said all the points which we keep it in a mind, so we try to mimic the in vivo environment, and media should give the stable and control environment. It should be allowing us to do some freezing or a genetic testing, and probably it should help us to improve the success rate. We all know that media development through the down the years, that how it has developed from KSOM and to now, and the requirements, embryo metabolism, single and the sequential, it will be in my second stage. So this everything you had very well said. This is all what you told, that salts and energy substrate is required. Anything you also want to add, Gaurav, or any panelists want to add here? Nidhi, would you like to add something more? Or Gaurav, do you want to add something?
I think Gaurav has very nicely and very systematically described all what we need to know the basics about culture media. And if we personally think about what we used, I have used both the things. Been using sequential media also at certain centers, and at certain we are using single step. So basically, media and the brand also, if you talk about different brands are there. So what brand you use, the quality is so good that it does not matter at present with the, you can say, plethora of studies which have been conducted, all are giving good results. Coming to the choice of media is depending on your few points, where you're putting up, which city you're putting up, what type of a lab setup you have, and also what is your footfall. If the number of patients or cycles are less in your, so I feel economically single step media plays a better role if you talk about the economics and the money matter. Otherwise, sequential, obviously, both are at par. So again, the selection of which type of media you're using is very, very dependent. Also, that city, if it is a small city, like I'm hailing in a small city, I've worked at different big cities also. So what is how the media has been transferred? Is the transportation? So these things have to be kept in mind when you're even selecting a media, whether it is sequential or single step, how frequently you have been there. So these certain points matter.
Perfectly said. Said single and stage, because there are many RCTs that said that in terms of outcome, it doesn't matter. It is choice of your comfortability, and a few prefers personal preference, even single step, and that is your own choice. Suhasini, what is your take on it? Dr. Suhasini, are you there?
Yes, sir. Ma'am, as we all know that, uninterrupted culture, we always love to have single step media. And if you talk about the sequential media, it is close to the natural mechanism. Whatever happens in the fallopian tubes on the uterus, the sequential will just mimic it.
Correct.
But then nowadays we are all, we wanted to have uninterrupted culture because time lapse is like everybody's favorite now. We don't want to have any disturbances. We don't want to have fluctuations in the temperature or the pH. And old days we used to have problem with the ammonium accumulation, which lead to imprinting disorders or
But now there are more stable amino acid like NLL. Yeah.
I mean, single step is giving it is serving the best purpose for embryo.
Exactly.
So naturally, I think everybody is moving to single step.
Single step with renewal, without renewal.
I think most of us are doing without renewal continuous culture till day 5.
Okay, done. So this is what we all are. This is the comparison what is I have done between single step and the sequential media. So that is a choice. Cochrane analysis says that in terms of outcome to live birth rate or a pregnancy rate, it doesn't has a difference. Few studies say it is better one on another, but majority says it's equal. So now coming to the next question, we are optimizing embryo culture like as a single step and sequential media based on the embryo metabolism and to minimize the stress for the developing embryo. And few new formulations of media which is coming these days are adding some additional supplements or bioactive additions or other development computations. So we do not know the complete ingredient of the mixture what we are using to culture embryo. So do you think these add-ons which is now into the new generation media, it is going to help us, or it is a hype, or it is just it's very hopeful? Dr. Sindhuja?
Yes, ma'am. Ma'am, so to answer your first part of the question, ma'am, can you go back, ma'am, please? So as we optimize embryo culture, how do single step and sequential media? So I think like Dr. Gaurav said, the composition of media is very clear. And in sequential media, it is differentiated into 3 different media, catering to the need of the embryo on the particular case. And the single step media is giving everything, and the embryo can take whatever it wants from the first day to the final day. So how it supports embryo metabolism is by the physiology of how it is made. Also, just one point I'd like to add in the previous thing also. So although we use one-step media, most of us use one-step media, some people still who are performing IVF like to use the fertilization or G0 media for the first day and then change it to one-step media from the second day. So that is also still happening. And about whether we need next-gen media formulations, so I think one step itself was like next-gen when we were using sequential media. So we've accepted that. And to be honest, none of them are actually really putting how much and of what is there in each of the media that we are using. Even though they mention it, the exact composition and whether it is truly that or not, we don't know. Sometimes when a media is outperforming the other media, I myself think, maybe there is something that we don't know which is added into this media. I think when you mean the bioactive additives, I'm assuming that you mean things like GM-CSF.
Correct.
All the other, maybe even growth hormone and the hormones
Correct.
that are being added into the media.
Yes.
So although there are some animal studies, long-term human studies are not there. So we have to use them cautiously. But for now, like I said, maybe we are already using them without our knowledge, and we have to look for the long-term effects.
Exactly. So very well said, Sindhuja.
Can I add a point here?
Sure, Suhasini, go ahead.
So, like Dr. Sindhuja mentioned, one step is it's like a next gen media that we are using now. But additional media or additional add-ons to this existing media may not be necessary at this point of time with the regular patients. But if you are going to be like customized embryology or a kind of a certain population of the patients like poor prognostic cases, maybe those are all the set of patients we need to upgrade our medias. Say like, we have already customized media which with the CSF with one brand. I mean, everybody using that, and we don't know how it is actually helping us. But maybe with a lot of literature coming into the picture, we can use these add-ons like, antioxidants or GM-CSF or any other cytokines or the growth factors which can really help in implantation or embryogenesis with this set of poor prognostic patients.
Maybe now antioxidants are adding and we do not know in the next, it can be there. And we have to just, wait and study that what is the impact on the live birth rate if we can study till there. So very well put on with your remarks, Suhasini and both, Sindhuja. So this is what the effect of melatonin. There are few literatures, as you both said, and it is the benefits of individualization if it is needed, customization or a tailor made for the needing, couple where it might help. So this is the thing which is going to come. Question 3: beyond culture media, the laboratory management system, the choice of equipment, we all know that it influenced the. Initially, it was a big box incubator, and with our improved knowledge, we tried that no atmosphere oxygen is not good, and we had this triple gas incubator which has improved and reduced the time for the recovery. So we have now time lapse and all that. So do you think that equipment choices also matters, and what kind of total quality management system is required for the better embryonic outcome? Abdas or Nishant, any one of you?
Ma'am?
Abdas
Yes.
or Nishant, any one of you can answer
Hello,
this?
am I audible?
Yes, please.
Yeah, hello, good evening, everyone.
Yeah,
So as you have already mentioned, beyond culture condition, we do want to extend for other aspect to be taken into considerations like proper temperature control, the gas level, where we can also lower down the oxygen requirement, because in dry gas, as we all know, that the oxygen percentage is quite less. So we would want to consider that as well. And apart from that, the VOC level in the lab should also take it into consideration, where we can install the HEPA filters in the AHUs and also have a Zend air or any kind of air purifiers in the lab so that we can reduce overall VOC levels. And apart from all these parameters to be taken into consideration, we should also take the calibration into account, that we need to properly calibrate in a weekly or depending on the footfall or number of the cases what we are handling. We should also take care that what is the frequency we want to calibrate the equipments, and all these parameters should be managed. Second, most important thing I would suggest is that the person who is handling the people like embryologists, junior embryologists, should also be trained enough to handle these all parameters, as well as how we are managing with the equipments. That we need to make sure that we are not opening the incubators for quite a long time. And even if we are doing it, we should not take it overexpose the dishes where the embryos are being cultured. And we should be planning the things which we want to do with the dishes ahead of time, so that we should know that labeling and everything should be done before incubation. So these are the basic things which needs to be taken care before we do these all things.
So Nishant, what do you feel that what is the minimum QC equipment the good lab should have their own in the lab?
When we need a good lab practice, so initially we need to have a temperature control, the lab stability, and also a CO2 analyzer, so which is very important. So it's like a daily monitoring your CO2 levels of your incubator, which help us to maintain the pH levels inside the incubator. So these are the minimum equipments what we require, and also VOC meter to check your VOC level in your lab. So these things help us to trace the lab function and also to maintain the good outcome of the embryos.
Perfectly said by both of you. Anybody
I-
wants to add something else?
Yes, ma'am. I would like to add something
Yes.
to this question.
Yeah, very.
I've been working with different centers, and usually I have this practice wherein I see that, whenever I go for this QC and KPI studies and I see the files, I always try to see any incident reporting has been done with any of the instrumentation before by any other embryologist, and what was the troubleshooting done, or any traceability that would help in future outcomes as well. So that is how I practice, and that has helped me through.
Perfect, because that is what reminds me that not only the having the QC and daily checks, QC sheets or a QC equipment, one should be open into the communication as a human being. If error might occur, it should be noted down. There should be internal audit, and it should be also once in 6 months as per the frequency and the cases load. We should have the external audit also, so that the total quality management system should be managed. And we all know there are so many things which directly indirectly affect the influence. This is one of my favorite slide which I had been using for many of my presentations. See, there is a few direct contact which can directly affect to embryo development, like culture media, ICSI needles, disease cryopreservation solution and all that. Indirect, if we do not maintain our sterility and the lab catheters, our vials, pipettes, rings, microscopes, equipments, everything which is we are using, it has the effect on the development embryo. So this is what pH, air quality, even light for that matter, gas phases, pH, as Agnes told that, I'm not very sure that who is having that. Do you think that the altitude, or if the person having a lab in a high altitude should have the different CO2 ferry?
Yes, ma'am, definitely. CO2 levels definitely depends on the latitudes and the longitudes that we are placed in. So there are places wherein, embryologists, they prefer from their different methodologies, they want to put it 6.1 or 6.2. And there are labs wherein, we just stick on to 6.0.
I have seen even 7, using, because and it was giving them a good result. So it's yeah. So this is an equation. Yes.
Call, ma'am.
Correct.
And what results they are getting at the end of the day.
Correct. And what about single versus group culture? Anyone wants to have their experience share? That what is your preference?
Ma'am, except if I'm planning to do non-invasive PGT, I prefer group culture, ma'am.
Perfectly. So what do you feel that what's the added advantage if it is not for PGT with the group culture?
That added advantage in the droplet culture or separate a single culture is that at least we can distinguish between the oocytes, and we can also demarcate while performing the ICSI that what kind of oocyte quality we have injected to. So in case of any kind of abnormality throughout, if we have even time lapse also, we can observe that which
If there
oocyte.
is a oocyte amorphism or oocyte abnormality, which as per the Istanbul consensus is going to affect the outcome, we definitely culture separately.
Yes,
But as per the Istanbul, I do not think any except the size of the oocytes is going to affect, right? Am I right, Sindhuja?
Yes, ma'am.
Yeah. So what is the advantage with the group culture?
Ma'am, it's the age-old autocrine paracrine factors, ma'am.
Absolutely.
Yes, ma'am. So it is definitely going to help with the development, and we do see. There are a lot of articles which are saying that even in single droplet culture there is excellent blastocyst quality. I do not disagree, but for me, group culture works better.
Absolutely. And what is do you feel that the drop size also matters? Because I have seen the lab, to save a little money, they are using, 10 microliter drop or something. So do you recommend that? Anybody? Gaurav, are you still there?
Ma'am, definitely the size of the droplet matters.
Yeah.
These days, I'm actually overdoing it by using well cultures, even if I'm using 4-well dishes.
Very
Because
good.
I really
Yeah.
feel the more is better.
Better. But in a 4-well dish, what I feel, because it is wonderful to have that, but if you are using the dry incubator, that's my personal experience, because the oil overlay is little, that is minimized. So if it is a humidified incubator, it's fine, but in dry incubator, it has little effect on the embryo. That's my personal
And one more issue we face with the 4-well dish, that even just to compensate loss of evaporation, we try to put more oil, which hampers the lid opening. It sticks to the lid and it hampers that.
Yes.
Ma'am,
So even I am very for the 4-well. So now my SOP, I use 4-well for pickup, and post 60 I shifted to the plain dish. Anyhow, this is the personal choice. Then osmolarity. Anybody would like to say that what kind of media and drop size and oil overlay is going to affect the osmolarity?
Osmolarity
So,
usually,
Yeah,
while
Suhasini.
yes, osmolarity is like a silent killer in IVF lab, because we don't have any measurements in the laboratory that regularly monitors the culture media osmolarity. We rely on vendors' parameters. Whatever they say, we believe in that. I don't think any lab has a osmolarity meter that checks
I had, initially,
very
not
rare,
now.
very
Yeah.
rare. I mean, it's not a regular thing that we have in the lab.
Correct.
And people who have habit of making small droplets on heat surface in the laminar airflow, they have the serious issues. And of late, we are seeing, the 2PN arrest is mostly coming from issues related with the osmolarity.
Perfectly said. And this is the study. This paper has published into the ASRM that the quantity of the oil overlay, whether it is, that is another big debate, that which oil, heavy oil, mineral oil, paraffin oil, that is a different thing. But the quantity of oil, particularly when you are using the dry incubator, it does matter. So these are the few studies I have noted down from ASRM 2018 and 2019 and Human Growth 2021. So where they have used dry incubator versus humidified incubator, where 3 ml overlay with 5 to 7 ml overlay of the oil, and they have studied that when you are using oil which is 5 to 7 ml, the blastocyst formation rate is better. So this is what one of the study. Reduce oxygen, how many says that's how many of you are still using the big box, and big box equally give, and how many are only favoring the bench top? All of you share their experience. Nishant, with you. Nishant?
Yes, ma'am. By using the reduced oxygen level of incubators, which it actually gives the better blastocyst rate when compared to box incubators.
Mm-hmm.
And also,
So you
when we see
use triple gas, correct?
yes, ma'am, we use tri-gas incubator.
Very
Though in tri-gas, we are using both like humidified benchtop incubator as well as the dry incubator. So we are seeing similar like conversion rate of blastocyst in both the incubators. But ideally, when we compare with the box type incubator and also the tri-gas, having low level of oxygen is always giving a better outcome.
Ferry, what is your experience?
Absolutely, ma'am. I would like to go with what Mr. Nishant just said. I would definitely prefer, because what I have seen in my practice with the dry humidified incubator, I've got good results, ma'am.
So
definitely
for successful blastofusion, the take-home message is very simple.
Yes.
Minimize pH stress in vitro, the good handling, good technique, narrow range, work quickly, appropriate conditions, oil overlay, the buffer media. Now also the buffer media, what we are getting, it's very stable, like Happy's, MOPS, or combination of that, and we should accept the changes that no, whatever I am doing is correct. That should not be the criteria. With that, I'll go ahead with the question 4. A new generation incubators, time lapse, and micromanipulation tools enter into the IVF lab. Evidence-based criteria should guide decision on equipment, selection, validation, and ongoing calibration to ensure optimum embryo development. I still am seeing in the few labs where the equipments are not under the maintenance program or AMC, or not having any QC equipment and all that, and it runs months together without even cleaning or monitoring. I do not see the QC sheets in the lab. So, what is your take on it, Nidhi?
The equipments are the mainstay. They are the incubators. They are the place where the embryos are grown. And like the question very clearly says, a new generation incubators. All the techniques with the new things are coming. So validation and, as you say, the quality control of the equipment. Even a ICSI machine or a manipulator which is 10 years old and it is properly maintained will give you equivalent result to a recently bought on equipment. First of all, this is the thing. If we talk about new generation and old. Secondly, again, equipment based is what we are selecting or what we are having. It depends on the workload. As I said, what if we are like, if I go to the previous question, ma'am, you asked a very simple question. Do you prefer benchtop over a box incubator? So if the workload is less and the number of door opening is less, a box incubator will or may give equally good embryos as compared to a benchtop. But I favor benchtop. I am not against it. I love benchtop incubator because again the recovery is everything. Again, so if we talk about this thing, should we whatever criteria where you are selecting these equipment, are they based on the selection due to the validation or ongoing calibration? Yes, they are. We have to when we are purchasing a new instrument, many factors play. First is again your as I just now said, footfall is important. The person who is using the instrument, how qualified they are, whether they are trained or not. What is the procedure you are doing? Normally you're doing ICSI, you're doing IVF. So depending on that, the selection of the criteria in equipments is important. So, ma'am, you have already anything else, ma'am, you want me to add on
No,
to this?
absolutely very well said, Nidhi, because the main thing is whenever you are opening a new lab, having instrument, I think like CO2 incubator, and now with the CO2 also we have a two-door system where you can open only the, the chamber what we want to open, so the other chamber is not disturbed. So all these things, what are the sensor, is it now, initially it was water jacket, but now preferably air jacket, the infrared sensors are preferable. So few things we have to go dig into it, that what is the things what we are using. Like, I agree that we are not biomedical engineer, but few things we should have the knowledge, that which type of gas we are using, which type of material is used, and from where this gas is manufactured, where, what is the, regulator we are using. All these things matter. And what is the recovery time between the two incubators. And a main thing is, what is our workload and how many number of incubators we are having in the lab. We just cannot load the samples either, because few bench tops we open, it is, 4 chambers, so we can keep 4 patients. So this is most important, that how to manage the equipment with the current workload and with that. So I think all should agree with that. Going ahead with the next question.
May I add one thing? Can I add
Right.
one thing?
Yes, Nidhi, please.
Somebody approached me and they asked me, ma'am, we are setting up our lab. This is mainly for the people because whenever you put up a lab, always think about little bit ahead of 20 years. What is your like location? Footfall is definitely there. So the construction of the lab can be there, but additional new equipment should should and can be added whenever the need is. So it is a
Absolutely.
step-by-step procedure. You should not overload your lab with multiple equipments, getting 2 box incubator, 2 benchtop, even when you're beginning. So start with 1 box incubator, 1 benchtop. That is the best combination to start.
Absolutely.
So it depends.
Absolutely. And depend the lab design, if it is a new, we can have that extra space that if the cases are increased, we can have another incubator installed. Very well said. So traditional morphology, we still feel, even I feel that, it's a gold standard with all added time lapse and all that. Do you feel that time lapse has really helped us to improve the clinical outcomes? Any one of you?
Definitely, ma'am. I would like to answer this question.
Oh.
So definitely this add-on has really given us very good help to all the embryologists who have been using time lapse. If we talk about morphokinetic assessment, definitely it has improved with time lapse, and we can, like the irreplaceable part for an embryologist could be we are just removing the dishes and seeing down how the embryo growth is there. But with the time lapse, absolutely, we can have this whole 120 snapshot at a go, and we can monitor and we can share it as well. And definitely something called as reduced embryo handling also is one of the major factor, which, like sometimes we seniors are not there and we have to
So
give it
you
to them.
are in a favor of time lapse. Agree. What
Yes,
are the opinion of all the panelists one by one? Because that is,
Yeah, so I would like to add one
Yeah,
thing on this.
yeah.
Yeah, so actually it's a good to have equipment in the lab, that it's modernized equipment which shows the morphokinetics of the embryos and to the blastocyst stage. But also we should consider that it comes at a higher cost. So this should also reflect to the patient. So if we are considering the cost also, then we can also incorporate in a normal scenario where the benchtop incubator is used for the culture. And by the end of day 5 and day 6, we can use a spent culture and non-invasive PGTA, where we can take out the any kind of abnormality is there, because that will give us a wholesome idea about the genomics of the embryos in blastocyst. If the patient doesn't have any kind of
culture
constraint,
media is added cost to the couple, no?
but as compared to time lapse, what they will be charging for to the patient, the non-invasive should not be the added cost. In that case, if the cost is equivalent, we could have gone for the invasive PGTA, which is a much more better for the results for the PGTA. Because in time lapse, just for the morphokinetics, we are getting to know any abnormality is there or not, but we don't know about the genomics of the embryo and blastocyst.
Ma'am, can I add something?
Suhasini, yeah, you have used time lapse so many years. So what is your take? Is it improving the live birth rate? Because I know you have thousands of patients data where you worked before.
Yeah. Two things here, ma'am. One is is time lapse is improving embryogenesis is one of the questions. If you ask me this question, it may not, because it is a normal incubator. It is only giving you more information about the embryogenesis. I mean, what is the pattern of cleavage? What are the timings of the cleavages? Any abnormal cleavage is happening? Direct
reverse cleavage, yeah.
cleavage, or reverse cleavage? What are the timings? It gives lots of information, but it is not going to give the better culture conditions compared to other benchtop incubators. So as far as the incubator purpose is served, both are same. What extra it is giving is morphokinetics and exact kinetics of the embryogenesis. Second thing is, this time lapse is very useful when it is paired with artificial intelligence algorithms. Because once it is clubbed with the artificial intelligence algorithms, it gives the ranking. I mean, it is going to reduce the time to pregnancy, because once you have 5-6 good grade embryos, for us AA grade is the top, and we don't mind to transfer 4 AA of any 5 embryos. If you have 5 4AA grade embryos, you can choose any 4AA and just transfer. But if time lapse is equipped with the AI, it gives the ranking which 4A has highest implantation potential. So in that case, you can pick the best one and you can go for the transfer. It is going to reduce the time to pregnancy for the patient.
Correct.
Apart from that, I don't think it has any additional benefits in terms of
Can I
embryo.
add something, ma'am?
Yeah, please, Sindhuja.
Yes, I think everyone's given excellent points, and ultimately, time lapse is helping us to reduce the time to pregnancy by deselecting embryos from the top quality embryos that are available. And hopefully soon there will be a lot of low cost time lapse systems. I think many companies are developing it, and it will also bring to the point which Dr. Mohammed has added, whichever can be incorporated into our system, and all of us can use time lapse, and maybe from that we'll have better.
So very well said that time lapse along with AI, like a Bella, which is taking 9 images of the embryo at a time, it is there, then it is fine. But till so far, the Cochrane what says that it is, as everyone agreed, that it is giving a good, all the stages developmental, rather than selecting it help us to deselect the embryo which is not fit for the transfer. But comparing with the other benchtop incubators and all that, time lapse has not helped overall to improve the pregnancy rate and the live birth rate. This is what many RCTs and the Cochrane says, but definitely I am also in a favor of AI and time lapse, because AI is a new tool. And my next question is on that only, that it's become an emerging tool. Rather in the gamete selection or oocyte selection, for the donor banks, for the sperm banks, and for the embryo selection, and how effectively you feel that it can predict the most suitable embryos for transfer. And given your choice that your your owner of your institute, or if it is your own institute, whether you will go ahead with the recent evidence that you will install an AI equipment for the embryo selection in your lab. I would like to hear in very brief from each of the panelists, because this is what it is the next hot, AI in our lab. So each of you should briefly explain AI in your lab.
Yes, ma'am. Firstly, I would like to answer your question at this.
Yeah.
So, as per my experience, AI is nothing but as how good is your image quality. So it talks all about the image quality. If your image quality is very good, and it can predict and give the outcome in a better way. So if your image quality of the embryos are not up to the mark, in those cases, sometimes AI might fail to update the proper answers of the embryo, like the morphology or the expansion dynamics. So when we compare the manual grading system and the AI grading system, so definitely it is giving better than the manual grading. But sometimes one example I would like to add here is sometimes the embryo hatching part might be on the opposite direction. When the manual grading system, embryologist, he will be knowing where the exact hatching is happening, so we can change the focus and then we can grade that particular embryo. But AI will not have that option, but it might fail to give whether the embryo is hatching or not. It might grade in the lower expansion as well.
Yeah, so that has few pros and cons about the AI.
Yes.
But in overall, you favor the AI in your lab, which might help you to, fine.
Yes, ma'am. I would like to add one more point here.
Yeah.
The labs, when it helps, like when there are multiple embryologists working here, so there will be a grading system mismatch. So sometimes one embryologist might feel that refractoderm is A grade, the other embryologist might feel it is B grade. So to get into one single conclusion, the AI help us in the proper
Absolutely,
grading.
there should not be any interpersonal variation that having the lab, correct. So any other points? So now Abdas,
Yes, ma'am. So Nishant very well articulated the points for the AI. as everyone would agree on this, that AI is in the cocoon stage right now, and it needs to evolve throughout. So in few of the it is a software basically. So it needs a data set in order to evolve. So as he also mentioned that if in a lab there are 3 embryologists, so there should not be any kind of interpersonal variations.
Right.
So in that case, the senior most or the person who will be responsible for the grading should at least, we should make one person so that it can be standardized. And until the decent amount of data has been uploaded on the AI, we should maintain that so that the quality of the grading which is given by the AI is
Yeah.
very much similar and what we expect.
Yeah.
And it should also be in an Indian demograph
Yeah.
rather than the foreign one.
Dr. Ferry?
Yes, ma'am. So definitely, I would support AI as I would take as a decision supporting tool for whatever I take the decisions, but it cannot replace any clinical judgment or any end of the day, we can depend on fragmentation or symmetry or cell division timings or whatever morphokinetics it gives down. But definitely at the end of the day, or also the scoring that it provides. But at the end of the day, definitely it cannot completely replace the embryologist.
Human
That is-
intelligence. Yeah,
Yes,
agree.
yes, absolutely.
Ma'am, may I?
Sindhu, yeah.
Ma'am, if we practically speaking, what I experience with AI is that it is an addiction, sort of,
Mhm.
and it is something that like ChatGPT, we cannot put a blindfold to it right now because
Correct.
it is the upcoming thing. And in the practical lab, like we talked about validation and interpersonal, you can say the trainees, the junior embryologists, the andrologists, and the senior, if you want to compare them, this is a very good tool. And also for me, in practically in my lab, when I am not present, I actually don't depend much on the semen analysis from my staff. Rather, I would ask them to take out a automated semen analysis and then compare themselves with the data. So in that way, it is training them also. Plus, it is reducing the workload of the center. It is making things very easy, like with just a drop, even if your embryologist is not present or the senior is not present, the person who is non-trained also can do a semen analysis. So again, coming back to it is making things easy for us right now. And we really need to, I am not saying that we should blindly follow AI, but we really need to embrace it right now. And it is the right time to learn about it.
Perfect,
In depth.
perfect. Because I think change is inevitable, and if any change is having a hope for the positive, we should accept and adapt that. Anything, Suhasini or any?
Just one point, ma'am.
Yeah.
Like Nidhi
Sindhu
has
Jain.
said, Nidhi has said, and everybody else has said, in andrology, we're almost there and we can trust it when it comes to semen analysis. But when it comes to embryology and embryo grading, just my opinion will be that if we are planning to incorporate it, which many hospitals are already doing, just like how we had to sit with the company for the IVF software and tweak it according to our needs in the hospital. Similarly, we have to tweak the AI software also to grade the embryos with the pictures that we are taking on a daily basis.
Absolutely correct. Very well
It
said.
gives kind of higher accuracy in predicting implantation, because what kind of data the AI development has taken, it plays a major role.
Correct.
Whatever data you give, is if it is a correct, accurate data that you fed with the AI, and if you are giving a correct information to it, and it will definitely give us wonders. It's going to help us to predict the implantation, and it's going to be like a second opinion for us for now. It's not
Perfect. Even I am waiting for it because it has added advantage, as we said, that any embryologist can learn, grading, and he can select the embryo. It can have that embryo viability and implantation, and combining it with other tools, I think morphology as well as morphokinetics, it will have that. And not only for our IVF lab, I think for the clinical side also, it is going to be very, very helpful for the embryo or ovarian stimulation and all that. So I
so
think
far, whatever the morphological evaluation that AI is doing, it's completely pixel level, based on its pixel levels and deep learning features. One is it
exactly.
is evaluating abstract pixel arrangements, textures, and kind of fluid dynamics with digital images. Whatever the data that AI is taking, it should be accurate. Then only we can rely on. People are coming with, we have 1 lakh embryo data that is already giving so many probabilities. The minute you add your blastocyst, it gives the probability of implantation. I mean, we don't know what kind of data they fed into the AI. We need to have authentic company that comes to us, give that, the confidence that they have fed the AI with the correct information.
Yeah, now few are coming up. You are also giving on the subscription model that you use. If you are happy, you continue. I had a person who said that he can keep a time lapse, he can keep the AI, he can, integrate with our EMS and all that. But the subscription model is too high at present to have that individual lab to accept it. So anyway, everybody agreed that AI is an emerging tool and we are ready to accept with pinch of salt, and of course with lots of evidence and lots of studies we can incorporate it, because there is no harm in it, except right. So now coming to the genetic part of the embryo, we all know we have ART Act in a place, and we all know that PGD and PGS is now a new name like PGTA, PGTM, and PGTSR. But M and SR, I'm not going to touch today. I'm going to ask you the question about PGTA. That what is your take? That does it improve the implantation? And as per our guidelines, which are the patients whom or candidates where the PGTA can be beneficial?
I mean, as per ART regulations, in our gazette, I don't think we have any regulations on indications for PGTA, but in ESHRE and ASRM, they have given a set of indications that who are the patients that are going to benefit from this PGTA. Kind of advanced maternal age, who is like 35 to 37 or 40 years more.
Anybody has a different idea than Suhasini? She said there is no indication in the ART Act. Anyone has the think? Anybody? Sindhuja?
When someone tells like that, we get confused. But I remember seeing recurrent pregnancy loss and severe male factor.
No, in an ART Act, there are 3 indications which is mentioned: advanced maternal age, recurrent implantation failure, and repeated pregnancy loss. These are the 3 candidates whom PGTA can be, maybe beneficial. But anyhow, so do you feel that PGTA is going to give a better pregnancy rate for normal population?
Ma'am, PGTA is patient selected based, I would say. If the patient is landing up in that criteria, like you have quoted 3 criteria, along with, I would say, very severe male factor also. It is not, I'm not talking about the ART Act. I'm just talking about in personal. If you go for a properly programmed counseled patient, and you have gone through the history, and if they are falling in any of these criteria, we have to offer them PGTA. Because first of all, no, the education is everywhere. Everybody knows about PGTA now. Even the people who are approaching for IVF, they know about PGTA. But not offering PG, I'm in that phase. I have faced very good results with patients who have been offered PGTA who are of advanced maternal age as well as paternal age. So, but if you talk about studies, both ESHRE and ASRM, and also very meta-analysis, they say that there is no difference. PGTA is giving you a better result after the PGTA, the pregnancy outcomes are better, or they are giving early to pregnancy. Again, there is not a big significant. The p-value is not significant. Irrespective of that, if you offer PGTA to such patients, ma'am, the compliance of the patient, it detrimentally improves. Because getting in an age group of 40 years, if a female is getting an abnormal embryo and an abnormal baby at the end of all the procedures done, then definitely offering a PGTA at the beginning is a must.
So
We
you
should
say
not be neglected.
PGTA should be considered for the indicated cases, right?
Yes, definitely. They
Not
should
for
be
the
offered
normal
separately.
population where they want to
No,
transfer the
no,
euploid
no.
embryo
No.
and a single embryo transfer. Definitely, it is added advantage that euploid embryo, when we are transferring, it will help us to transfer the single embryo transfer.
Yes,
Correct.
definitely.
Yeah,
With
yes, ma'am.
single or multiple etiologies also, ma'am, definitely miscarriage risk and implantation potentials will increase. But as Dr. Nidhi mentioned, definitely there is no exactly exactly we can go with this PGTA and it shows any data for it. So
Again, the
definitely.
negative aspect of PGTA has to be considered into mind, ma'am. What epigenetic changes can happen, what stress can happen on an embryo.
Yes.
Secondly, is the PGTA 100% the specificity and sensitivity of the test?
Yeah.
And what lab you are selecting. So these factors do play a role. So it should not be offered normally as
Absolutely. Because if we
Yeah.
see the quality and quantity of gametes that we all are getting these days, and if we see definitely there is higher rate of developmental epigenetics.
Correct.
Sure.
So now I think everyone has shifted from cleavage stage to trophectoderm biopsy. I think you should all agree that we all are doing trophectoderm biopsy. Is there anyone who is doing day 3 biopsy here? Hello?
No, ma'am.
No, ma'am.
Fine. So now we are associated with all genetic lab, and I agree. Few days back we have a webinar on the genetics also, and selecting a various genetic lab, and they are doing NGS and the platform or SNP or something which is going to whole genome sequencing and all that. But still, sometimes the report is said no DNA detected or the mosaicism, and there is no standardization globally that what percentage of mosaic embryo you are going to transfer, in terms of we do not have any other embryo for the selection. I want all of you, your personal experience on that.
Yes, ma'am.
Yeah.
I would like to answer on this.
Yes.
When we see when we send couple of embryos for biopsies, and the major thing what we are facing is now low-level mosaic. So ideally the low-level mosaic is like both euploid and aneuploid cell population is there in that. But now few studies what they are saying is we can transfer low-level mosaic also, and which is giving better implantation rate also. And few papers also which has been reported a healthy baby also on the live birth.
So
And
low
few
level
case,
in terms of what is the percentage you are mentioning here?
the mito score should be less than 50.
Less than 50. Okay.
Yes.
So
And
this
few
is your
scenarios.
SOP that if in terms of where you have no other embryo, the less than 50% of embryo you are going to transfer. And if you do
Yes.
not have anything, and if your only embryos is having, which has a more than 50% this thing, you'll cancel the FET or you will do?
We cancel the transfer. And also here one point I would like to add is with our experience, few low-level mosaic embryos we did rebiopsy. So those rebiopsied embryos were turned to be euploid embryos in the second attempt of biopsy. So then we have transferred, and we have got a pregnancy also, which is ongoing pregnancy now.
Oh, okay. Anyone's other experience than this?
For literature, many studies have shown that ongoing pregnancy rate and live birth rates with the low-level mosaic embryos is comparable with the euploid embryos. Often,
Agree. Yes.
which is like less than 50% of abnormal cells, because of it has the self-correcting mechanism. And there is a lag in the replication where there is a abnormal cell, and it undergoes targeted apoptosis. That too, if the low-level mosaic is reported in segmental mosaic, and absolutely this is like a green light. You can go ahead with the transfer if no euploid is available. Only the stop is where you have more than 50% of abnormal cells, which is like a high level mosaic embryo with whole genome, whole chromosome mosaic.
Yes. So,
That's
yes.
lower ongoing pregnancies and higher miscarriages.
So very well said by Nishant and Suhasini, and these are few of the evidence and the studies which I can collect about the mosaic embryos.
Ma'am, I would like to point out here, my
Yeah.
fellow panelists have really put out very good points. All these data which is obtained, is it like from our ethnic population?
I don't think so.
Yeah, that's what, because it plays a very major role.
I know we have tons of data, but we do not have that kind of study. I think our next webinar should be that. Are you ready to have this kind of paper? Let's go and publish this, because that's what we are lacking, I believe.
Absolutely, ma'am.
Yeah.
This is
May
what
I add on to it? Even if it is a low mosaic or a high mosaic in certain cases when the embryos are less, I would always prefer two things. Number one, patient should be well informed. Number two,
Yes.
counseling of the patient has to be done in verbal as well as written form, so that if there is even 5% or 15% chances of the embryo either landing up into a miscarriage or further having an abnormal genetic or any changes in the baby or abnormality in the baby, they have to be well explained about the consequences. And also the second part, during the pregnancy, what all test has to be done. So the proper counseling of the couple has to be done when a low mosaic or even a high mosaic embryo is transferred.
Absolutely.
In few cases.
Absolutely.
We
That
do
is
have
always
a
there.
hierarchy. We do have a hierarchy when we select these embryos for the implantation.
Yeah.
We go like, euploid embryos, followed by segmental mosaics, followed by low-level mosaic with less than 50% of abnormal cells, followed by high-level mosaic. All this happens once the patient goes for PGTA or PGTM or PGTSR. Every patient has to go through geneticist assessment. They have to go with their counseling and take the written consent, then only they go for the implantation.
So fine. So we all has agreed that low mosaic, and so we'll go with the next question about the what we say called omics, where we are not. It's non-invasive, studying either proteomics, metabolites, or transcriptomics. Do you feel this is going to improve our embryo selection, and where do you feel that it should be considered as a main test in our IVF lab for in terms of the so far studies or evidences?
Ma'am, we can definitely go forward with this omics that are now mostly emerging. But then the major question comes over here, that what about the expensive? Because when we talk about this metabolomics and proteomics and transcriptomics, the thing is we are talking about genetics and we are talking about molecular biology, and which is very, very expensive at the end of the day. So this is one of the inhibition, you can call it a limitation, that we can go with this. We can calculate the glucose and pyruvates, and we can also go with the expression
just
profiling.
assume that maybe with the time, because initially everything was very costly, with the due time it is becoming kind of reasonable cost. Now coming to think that if you feel that PGTA and this is more or less equal, what is your personal preference, that you will still go for the non-invasive like PGT, or you will jump into completely in the omics?
Again, ma'am, it depends upon the patient profile and the etiology and the case I'm handling. I would definitely look into that factor majorly, rather than going into all the investigation and all the possible things that I have in hand for reporting.
Perfect. So you feel that it still is an emerging tool where it should not be considered as in the mainstream. Am I right?
Absolutely, ma'am. Absolutely. Because even if we see all the embryologist profiles, there are few who are interested into research. There are few who aren't.
Yeah.
So they might not be comfortable enough to go into all these detailed analysis.
Anyone would like to add something?
Yeah, ma'am, I would like to add on that.
Yeah, okay, please continue.
Please go ahead, ma'am.
So for omics, I'll take a step back because, ma'am, it depends where you're sitting, as Dr. Ferry very rightly said. So if you are sitting in a center which is have a well-established lab, you are well-funded, why not? The question is, why not apply omics to all the patients? Get a
But
very
still you
wonderful
will,
data.
Nidhi, you will see na, okay, find funding, and that is one thing. But still you will see that what is the evidence, what is the study says, what is the
Yes,
concordance.
definitely, ma'am. But we don't have data. We need, like you are saying, ma'am, very rightly, we need the data. To do the data, we need funding.
Yeah.
So omics, if you see at animal level also, ma'am, I have only read about it. See, I've never done it. I've never seen it. For me, omics is the topic which I need to study for IVF. It's like that. So,
But unlike,
yeah, but why not
unlike
apply
something like AI and all those things, omics is not something new. It has been there forever, ma'am.
Yes.
No,
yes,
few
that's what
companies
I'm
are
saying. But we
offering
need to
here.
bring it into practically.
Yes,
Nee, ma'am, we need to inculcate. Why I'm saying is, if I'm sitting at a research center, I would definitely love to do it because I have worked at big hospitals also, like Maulana's. And why not? My question was always
Everybody
that,
will
why not
agree on one point of the decision making, that non-invasive is always a better approach
Always
rather
better.
than if patient is improving only with the tablet, why to do surgery?
Ma'am,
Right.
even
So
right now,
this
all
is
the
what,
studies are
if
saying.
the future study says that concordance is matching, with right now I feel it is somewhere around
No,
80%.
no.
So it is something which, because there are lots of things which is included, contamination, less DNA, embryos, and then many factors which has to be, but maybe research is going on, emerging is there, and something which comes up and it helps us to do something. Maybe in a future we should keep our thoughts open, right?
Ma'am, can I share just one view
Sure,
on this, ma'am?
sure.
So, ma'am, let's take the example of DNA fragmentation, ma'am. So, as we've theoretically studied, there are so many different methods of assessing the DNA fragmentation. Some people assess oxidative stress, some people measure different components which cause DNA fragmentation. But ultimately, for a clinician, only when they say, is it a single strand DNA damage or a double strand DNA damage with an SCSA or with an advanced test, they're able to believe that there is something wrong with this sperm. So same way, I think even around the embryo, whatever we do with omics, AI and all those things, unless we directly look at the embryo and say that this is what is happening with the embryo, it is going to be very difficult for anybody to believe that we are really giving information about the embryo.
Correct.
So we have a very long way to go. It will be very interesting to do it, but I think this is one reason why it has not progressed beyond the research level in all these years.
Correct. Very well said. So now, do we have time to take up the question, Dr. Kalpana or someone, or shall we close here?
Yes, ma'am, we are running short of time, ma'am.
So I'll take the last question here and stop.
Yes, ma'am. You can, ma'am.
Fine, done. So now, the spent culture media, as I think it has been answered, because the current limitations, what we say, it is a diagnostic accuracy, right? Anybody would like to add more here for the things?
Yes, ma'am. So, lastly, in last question also, I had the same thing to add, that lots of variability is there. The person who is doing the spent culture media checkup, it can be in the lab and also where the testing is happening. So the specificity is a problem, and also there is no standard how they are going to do it. There is no standardization because the yield what we get from CF DNA is quite less. So if we are not doing it properly, at the end of the day, we are left with no results at the end of the test and everything.
Correct. So still it is in the research. I am not going for 3 questions because we are running short of time. I'm just adding that as a take-home message or a conclusion, that no single method can fully predict the embryo potential. Either it can be morphology, time lapse, culture condition, or genetics. So we should have that, kind of 360-degree integrated approach to select the embryos which has a higher chance for the implantation, not only for implantation, for healthy live birth. So we are combining and we are optimizing a culture system, maybe with the morphogenetics, genetics, wherever screening is wherever indicated, And we are waiting for future innovations like AI and non-invasive omics to further enhance the embryo selection. I think we all should agree on that point, and we should have that multimodal strategy for the decision making. Thank you. I thank you all of you for taking time on the working day and having lots of discussion which has some kind of take home message. Thank you everyone. And with this
Thank
I'm
you.
Thank you, ma'am.
stop
Thank you for
my sharing.
and both of you, ma'am.
Yeah.
And very well, wonderful panel, ma'am. Panelist also.
Thank you, ma'am.
Yes.
Really, we had a very enlightening session, ma'am, because of all panelists, and it's a very interactive session. Thank you so much, ma'am, for sharing your knowledge.
Thank you so much,
Thank you,
and
ma'am.
thank you,
Thank you.
Dr. Kalpana. Thank you for Foxy. Thank you all organizer for having us here, and would like to continue with this, with the knowledge sharing, and with all our colleagues and our juniors. Thank you so much, and have a good evening, every one of you. Thank you.
With this, we
Thank you,
conclude
ma'am.
the session, ma'am. Thank you, everyone, for this webinar, ma'am. Thank you.